Okay, so I was put with the task of giving you guys updates on COVID. This has been getting updated almost like every 3 months when I do this presentation. The lowest was, I think the shortest was maybe a month before I was updating it again. So here is actually the pictures that you see here are actually CROI. This is the HIV International Conference. It was actually one of the first meetings. I think it's not the first meeting that ended up going into virtual because it was scheduled to be in person the weekend that we got the first COVID here. So it ended up becoming in person. And so with that, the objectives for today, I'm going to briefly talk about the EPI. I think most people know the numbers, but we'll just do a few updates on that. The workup and the management and try to do it case-based. And then touch on monoclonal antibodies and vaccines, which I think is the thing I kind of want to focus a little bit more on. So SARS-CoV-2 or COVID-19, so it's, you guys know now it's an RNA virus, it's envelope. It was identified January 7th of 2020, so it's not even 2 years old. It was, the first case was that it was noted as pneumonia of unknown etiology, reported back in China, December 8th of 2019. But not reported to the WHO until December 31st of 2019. At that point, the case fatality was 1 to 3%, and then a global alert was sent out January 30th of 2020, and the pandemic declared on March 11th of 2020, and this is actually when the conference was made virtual. This is from the Hopkins website, and one thing is I do have an email that's delayed sent that has a lot of these websites and resources, and a Google Drive that will have the articles that we talked about, so that will be sent after the lecture. But the main thing is Hopkins is a good resource from the very beginning. So as of now, this was yesterday, you know, there have been 232 million confirmed cases globally, about 4.8 reported global deaths, and then the amount of vaccine doses you see here, it doesn't mean that they're covered with the 2 doses and what type of vaccine it is, but at least they do have documentation of how many doses have been available. And if you see this number, you kind of see, I want you to kind of focus on the number here and how many people have received the vaccines globally. When you look at the number of cases, the US has, you know, topped throughout the whole past year and a half. And some of this could be testing as well and access to testing. And in terms of deaths, you know, the US has been #1 each time that I've done these lectures. So again, some of it is testing and even just writing COVID. And I know, so, you know, a lot of places, even in the US, they, you know, patients' families don't even want to add COVID to their autopsy. Pictures here are from Wes during the time of the pandemic back in spring of 2020. So in terms of the CDC website, this gets updated. So this was September 27th as of 3 p.m. There have been 42 million cases, or 43 million. 31,000 new cases of, you know, so 666,000 cases in the last 7 days. And you see here the total number of deaths and then what they were reported in terms of the last 7 days. I've been updating the case fatality rate each time I kind of been updating these slides, and you see that the numbers have kind of, depending on the range of what's being reported and testing, but at this point we're at 1.6%, and then what was done in the last week. The disparities you will kind of touch on, but just to kind of see where are the cases occurring right now. The blue is, you know, you see is the South. We're over here, you know, Texas is where my family's at, but as you see here in terms of where the cases are, then we do have this pocket here. Deaths, you know, through this deaths is reported since the January of 20, and these are, sorry, so the information here is from January of 2020. So from the very beginning, so deaths and cases, the same area in the South. This is the New York City website. If you haven't gone to the Department of Health, like they're really good about reporting the information, and it's very useful for us as providers, clinicians. So I always keep this because this is us in spring of 2020, and this is the time that I was mentioning, you know, this big peak, and not just looking at the graphs and the dates, of course, also look at these numbers. So here we're talking about numbers of 2,000, 4,000, 6,000. And then you go, and yes, there was a little of a drop here, and now we're going back up. And then here's the continued drop and now going back up. But see the numbers here, now we're at 715 and 1500 and not what it was before. And the same thing goes, now this is the latest data. They update their data every Thursday. So this was from last Thursday. And so you can see cases are up, but numbers are what you see here. Hospitalizations is the other thing too. When you look here at what was, 500,000, 1,500, again, this is the peak. Drop here in the summer of last year, and then now continuously going back up. But again, we're talking about 75, 150 compared to 1,500. And deaths is the other thing that is a big thing that's a difference that many of us who were here at that time is the thing that we're still wrestling with. But again, the number of deaths here versus now where we're at recently. And so for the crown, why coronavirus? It looks like a crown. Most people now know the spike S protein is the one that we look at. I know there was a lot of talk about the ACE2 receptor, and there still is some talk regarding some of the treatments. Novel coronaviruses, we have SARS, and then we had MERS back in 2012, and now we have COVID in 2019. Lit COVID, if you haven't looked at it, is basically PubMed focused only on lit COVID. But the nice thing about only on COVID, the nice thing about this is that when you go on there, there's a bar that lets you focus on literature on treatment, literature on diagnosis, so you can actually gear your search on what you want to look at in terms of COVID. And you see that, yes, there is a vast amount of publications, and where they're coming from is really throughout the world, the US, but also here. Where is transmission? I think, it's respiratory, I would say, it's rarely culture as we're seeing here. Vertical transmission now, there's definitely data that there is some vertical transmission. And the most recent, reproduction here, this was from not what we're going to talk about in terms of variants, but at this point it was 0.91 is what people were thinking about. And at this moment, we do have, let me see how many. 13 players. So the first question is going to be a 69-year-old female with a history of schizophrenia, COPD admitted with fatigue, generalized weakness, body aches, dyspnea on exertion, cough, diarrhea for about 2 weeks. The safe febrile is on 100% on room air. No wheezing. You've seen the labs there. She is tested positive for COVID. What is the most appropriate management? And sometimes the funny thing is just the names, but so we're going to go ahead and start. So what is the appropriate management for this patient? So are you going to start remdesivir, get convalescent plasma, think about doing monoclonal antibody, or do supportive care? Okay, so very good. So majority, and actually this one has, so let me go back to the slide. So yes, so the answer was supportive care, and you see the inflammatory markers as well. And I think this, I just want to highlight the duration. You don't know what the duration is. Synthesis has probably been more than 10 days for inflammatory markers you're seeing here. So it was supportive care. Next question is 51-year-old male, no significant past medical history, transferred to Morningside with 5 days of fever, chest pain, shortness of breath, is acutely ill, appearing, has work of breathing, is on oxygen, has some opacities, COVID positive. So patients evaluated by ID, was started on remdesivir. Which of the following discontinuations parameters is not correct regarding remdesivir? So at what point should you stop the remdesivir is basically what you're trying to answer. So at this moment, we have Joe getting there, but it's a close game right now. So which of the time, so that at what point should you stop the remdesivir is like the way to think about it. When the patient's intubated, when the LFTs are above 5, when the patient's medically stable to go home, or less than 30. So when should you not stop the remdesivir? I guess sorry, I misread it. So when should you stop should you not stop the remdesivir? Very good. So even though I kept on kind of going, very good. So yes, so you should not stop it just because the patient's intubated. You can continue, you can stop it if the person's going home. You should stop it if the LFTs are high. Controversial about the renal function, but I think right now that was appropriate. And so for this, you just see that the LFTs did rise a little bit, but it's reasonable to continue the remdesivir. Now, this is a nice graph that, again, is included in the articles that you're going to be sent. So just duration, we now know, depending on the viral response and the person's own innate immunity, and also how the host inflammation response is occurring. What are the clinical symptoms? At what point do you think that this is appropriate? And this was a nice graph that was early on done, including some of the information regarding inflammatory markers. Where are antivirals working? I don't think, now we have this hydroxychloroquine, but this is a nice, figure just talking about where TOSI, where were the thought process for TOSI, convalescent plasma, what was the thought process, but the main one we'll focus on is remdesivir. So remdesivir, issued EUA back in May 1st. Now it's FDA approved as of October 22nd for people who are above 12 years of age and at least 40 kilos. The work of how it works is basically, delayed chain termination during viral RNA replication. There's two different studies here. One is the ACT-1 that showed that, that in the patients with hospitalized patients with lab confirmed COVID, they had shorter duration of symptoms and improved survival. WHO did not demonstrate mortality benefit. I think, right now we do know that it's about duration of symptoms and how long the person's had them. And we do know that now we say less than 10 days would be reasonable to go ahead and start. And I think of it as more as like Tamiflu for remdesivir. And that's what it says here, the first quartile 7, when you separate duration of symptoms, you see that there was more improvement than the individuals that did not, the duration was longer. And, for me, remdesivir, I am a little bit biased because I was involved in the clinical trials for Gilead, and I felt like the first weekend that we were enrolling, that this was the first time that I actually saw people being de-escalated on oxygen requirements and being able to go home. And we were able to start enrolling within probably 3 weeks of our first case. And I think, to me, that's where my bias is coming from, is just being able to see people actually be de-escalated and be able to go home for the first time. In terms of steroids, we do now, it's recommended for people who are confirmed COVID. It's not recommended or found to be beneficial for those who have not required oxygen support. And the benefit, has been seen people who've been 7 days off onset of symptom onset. What is it? 6 milligrams either POIV for up to 10 days. And of course, you're looking for hyperglycemia and secondary infections. The study here from the recovery, it's a control open label trial, people hospitalized with COVID given dex versus placebo for up to 10 days, and the outcome was 28-day mortality. And what they saw is with dex, you were able to have a lower 28-day mortality among those receiving invasive mechanical ventilation or oxygen alone, but not those that did not receive respiratory support. And this is the data here that we're seeing. Convalescent plasma, so EUA was given in August of 2020, and this was revised February 4th because there's a lot of controversy about this because, a lot of different a lot of different studies were saying there was some benefit, others not. This one here from recovery was an open label RCT that said, among patients hospitalized with COVID, high titer convalescent plasma did not improve survival or other outcomes. But now the NIH panel does recommend, at least for those who have impaired immunity, you do recommend for treatment of COVID-19. When we say impaired immunity, we're talking about these case reports of patients with impaired humoral immunity, that when you gave the high titer convalescent plasma, patients were able to be improved. So that was given was given EUA in February 4th. So basically for people who are hospitalized with COVID-19 impaired immunity, that's the role for high titer convalescent plasma. And that's really the only time that now we're kind of arguing to give convalescent plasma to those individuals. TOSI, IL-6 inhibitors, yes, as being the first COVID attendee here at Morningside, I was giving TOSI, but I wasn't giving TOSI to the right people because we were giving it to the people who were already intubated. So now we know that the IL-6 inhibitors, the dose will be, it's one dose of 8 milligrams per kilo with a max of 800, giving it with dexamethasone. Now it's recommended for people who have been hospitalized within the first 3 days, but are admitted to the ICU or now getting escalation of oxygen needs. And the thing that you're looking for is a CRP of above 75, and again, escalation of oxygen requirements. Now, the thing is with TOSI is you do want to make sure that you're doing some screening for TB at least, and then thought of maybe spondylosis screening, and maybe for some, and I would argue maybe everyone, but to think about, do we need to do preemptive ivermectin for concern for spondylosis? So you can just send a spondylosis antibody, again, because again, this is for the IL-6 inhibitors, TOSI. So JAK1 inhibitors, so the EUA was over in November of 2020, but we've just started kind of rolling it out more at Sinai. And so the JAK1/2 inhibitors, this is unique because it's oral, and that's from the ACT-2 study. So this was a randomized placebo-controlled trial, patients with COVID-19 given 1-to-1 for up to 14 days with remdesivir. And they were given basically the JAK1/2 inhibitors with remdesivir for 10 days. And what they saw is people who received this combination had a shorter time for clinical recovery from 7 versus 8 days, but it was more pronounced in people requiring oxygen versus those with invasive. There was no difference in mortality. Main thing with these JAK1/2 inhibitors is you are monitoring LFTs and you have to screen for TB, but it is contraindicated for those who are CKD. So something to be aware of. And how it's postulated that it's working, it's trying to inhibit the COVID from entering and infecting lung cells, and it reduces inflammation and lung pathology, as was seen in basically animal models. But again, so just something to be aware of because we do have it and it's part of the guidelines now at Sinai. And now the updated guidelines from Sinai from September 21st. I think this is the 10th or maybe more revision from the original, but focusing more on the hospitalized patients. So if someone's just on nasal cannula requiring oxygen support, you're thinking about antibody treatment versus dex or remdesivir. Remdesivir does require ID consultation, but it's kind of like, for us, it's like a cefepime approval. Convalescent plasma, I mentioned now, high titer convalescent plasma for select immunocompromised individuals with discussion with ID, and then steroids, I mentioned. For those who are nasal cannula, high flow or BiPAP, you may consider, doing JAK1/2 inhibitor or an IL-6 inhibitor. But again, this will require ID and critical care involvement, and just thinking about just screening for TB and spondylosis. There is a shortage for TOSI, but I think right now we're okay at the sites. And really for TOSI, the main thing is just escalation of oxygen requirements. As far as I know, we haven't given one of the JAK1 or 2 inhibitors at either of our sites right now. And then for those who are intubated or requiring ECMO, at that point, it's really, we can consider dex and TOSI, but remdesivir has really not been recommended now because there's been no proven benefit at that point. Okay, so next case. So we have a 46-year-old male. He's actually one of my patients who has AAC 4564, 37%, undetectable. He's on Genvoya. Calls me, tells me I've been short in breath, has had dry cough for 3 days, febrile. You see his labs there, chest X-ray with patchiness in the left lower lobe. He's found to be COVID positive. Besides evaluation for remdesivir, what are the next steps in the management? And this is a true case. So after that, so at this point we have SID. So again, it's not about correct, but how fast. So here, besides evaluation for remdesivir, what are the next steps in management? Select all that apply. Start antimicrobial treatment, start Bactrim with steroids, start meropenem, hold the HIV meds. Which one do you think? So this is more than one option. Okay, so very good. So your repeat CD4 was 195, 25% on this patient. So yes, I actually got called by the hospitalist, should we go ahead and just empirically treat for PCP? And they did do the antimicrobial and the Bactrim and steroids. So just not anchoring on one diagnosis is the key for this question and thinking about others. And so for their concern was, should we cover for PCP or PJP? Next question is 62-year-old female with a history of HIV/AIDS, CD4 1236, 39% detectable, diabetic, hypertension, calls me by her. Oh, thank you.
Can I ask you a question about that previous case?
Yes, but then you give me your time. Go ahead.
Oh, I'm sorry. If you knew that CD4 count was only within the last 3 months, the 500 one, would you really treat them for PCP for that low CD4 count if you knew it was probably low because they had another infection?
Yeah, so at this point, this was in March of 2020. At that point, I said yes, but when we discharged him, he didn't go with PCP treatment because it's correct. Yes.
Okay.
I think the goal of the question was more just for not to anchor on a diagnosis.
Okay, thank you.
Okay. And I thought maybe I wasn't sharing the screen, so I hope you guys can see this. So the question here is that she sends you a my chart that tells you that she was tested positive and she had headaches for 4 days straight. And that was her my chart. It was all capitalized. That started on 12/12, and so she went and got tested, and on the 14th she was positive. She had no other symptoms. She has an appointment scheduled for January 25th. And she's asking, should I get another test before coming to my appointment? And she says that she has no symptoms and is feeling better. What do you recommend? So let me get to. So here we're still with Sid, but still close, you guys. So here is a single choice. So what would you recommend? So we schedule appointment for April of 2021, needs to document COVID PCR negative before able to make appointment. Is able to come on January 25th and doesn't need any further testing. You need to get a chest x-ray when she comes. So what do you guys think? Very good. So I think that's why I do this, to kind of see where you guys are at. So yes, she's okay to come and she shouldn't get any tests, and that's meant to be 2021. Now we know, like, where should we do the testing, how should we do the testing, and when do we think that maybe we should consider repeating testing if someone is high suspicion for COVID. And we know now, like, depending on duration of symptoms, that maybe it is okay to keep someone under suspicion while you repeat the test. And we do know now that nasopharyngeal is good sensitivity and specificity. It's all just depending on the viral burden. And I just kind of want to highlight the saliva testing that's available now. I did send the article. I'm not going to talk about it, but the article kind of comparing nasopharyngeal and saliva testing, and they seem to be reasonable. It's universal testing as of the 2020s for us. You do have to get testing before someone gets sent to SAR, and this is one of the, and actually on God's right here, Dr. Kojic talking about one of our first patients over at West with the residents, with your colleagues. Inpatient rapid, it still hasn't changed. We do only get a certain amount of cartridges to be able to do this rapid testing. So it is correct that you still need to get infection prevention to get approvals for our rapid testing, not the ID fellows, not the ID team, but specifically only infection prevention. So that's why on call, there's always someone for infection prevention that will approve these. And they're the only ones, from a division of ID perspective, it's not changed. They're the only ones that can approve the rapid testing, but also can remove isolation. Terminology now, quarantine someone who's been exposed and you're trying to keep them away, and isolation is someone who's been sick, and just knowing the different, signs that you guys are seeing now. Just one study, there's multiple studies now, but one study focused on patients with HIV, 286 patients, and this was a US study looking at just outcomes and hospitalizations. Majority of patients were on HIV meds for the ones that were enrolled, and the 89% were suppressed. Majority had comorbidities, and what they saw is, yes, older age, chronic lung disease, hypertension, patients with lower CD4 counts were associated with decreased survival, but there's really no association between use of ART, because at some point that was a concept, like, is there any antiviral effect of the HIV meds with COVID? And another study here looked at multi-center research, but looking at comparison with those who don't have HIV. And what they found is really there's no, when you do one-on-one matching, there was no difference in mortality between patients who are HIV positive or negative, and this is what it's saying here. So next one is 57-year-old female with no significant past medical history, came into the ED with shortness of breath for 7 days, noted that she went to North Carolina a week ago with and had generalized malaise at that time, came back to New York City, got tested, was found to be positive, says that she had 3 or 4 days of body aches, malaise. Her son is a doctor, was prescribed azithromycin and favipiravir that you're seeing there. She's afebrile, she's on 92, 94% on room air oxygenation. You're seeing the labs there. Chest X-ray, really no opacities noted at that point. She's found to be positive. What is the most appropriate next management for her? So Sid and Joe, and Jonas I would include, because again, it's not about just being correct, but fast. So what is the appropriate next management? So continue what her son prescribed her, start DEX, evaluate for monoclonal antibody, or start anticoagulation. Okay. So yes, I would argue, we'll talk about monoclonals and risk factors and things like that, but for this individual, that's the answer I would give. Next case, and we'll talk about why. Next case is 77-year-old male, history of CAD, diabetic, presented at ED with 1 day shortness of breath, hypoxia. BiPAP was started, he's lethargic, inflammatory markers you see, CRP is 2.5. Chest X-ray does have some opacities with effusion, is found to be positive. In addition to starting empiric antimicrobial therapy, which of the following studies should be done next? So here we have, it's still close. Okay, so in addition to antimicrobial therapy, which of the following studies should be done next? So CT chest, influenza PCR, COVID antibody assay, or echo. Okay. And some of these I kept because you see how much has changed even in just the management in these last year and a half. So I agree the COVID antibody assay, it would be what I would do. Next question is 68-year-old male with diabetes, hypertension, seen by televisit by his PCP with 2 days of dry cough, shortness of breath, and subjective fevers, had Pfizer series completed. He says that he's having oxygen saturations of 95 to 98% at home. He feels well, but he tested positive for COVID. What is the correct statement regarding monoclonal antibodies? And I give you, and actually I should update that one because one of there is not used anymore. We'll go into why. So right now, almost there, okay. So next one is, what is the correct statement about monoclonal antibodies? They decrease COVID hospitalizations, ED visits. They lower the severity of symptoms versus placebo. They have a greater reduction in COVID-19 viral load, patients who receive it, all the above. What is the correct statement about monoclonal antibodies? Very good. Yay. Okay. So, okay. So So all the above. So assays, very briefly, like I know the problem with assays, and again, to this day, we're going to say doing antibody testing, we don't know what level is protection and we don't know what level is immunity. So again, that's the only comment I make about antibody testing. So combination that we have here is the Regeneron cocktail. So this was given EUA back in November of 2020. This is targeting the spike protein of COVID. You know, we get allocation to the federal government, but it's approved for people 12 years or older, over 40 kilos. And here it's actually less than 5 days of symptoms. I would tell you the Sinai guidelines a little bit. And at first it was given as 1,200 of each combination. Now we say it's 600 of each, and it's infused over 1 hour. Really, side effects are, you know, some anaphylaxis, infusion reactions. You just have to monitor for an hour. High risk, who is high risk for severe COVID? I would argue that you could probably put a lot of people as high risk. So, and you know, I think for me, I kind of try to be more open about who gets monoclonal or not. But this is really the recommendation for like who is at high risk and should be receiving monoclonal antibodies for treatment. You know, one study here just looked at, you know, the primary endpoint was the average daily change in viral load through day 7, patients with high viral load. And this is what I was saying, that patients with high viral load at baseline were able to benefit more with this cocktail. And they also had less COVID-related medical visits after the original cocktail was given. And this was seen even with people who had combined, who had comorbidities. This is another combination, bamlanivimab and etesevimab. So bamlanivimab I'm going to talk about, but now this combination was approved on February 9th for EUA. This is the one that we have mainly here in Sinai, but we can get this one. But this was approved for EUA February 9th, again targeting spike protein. And again, you know, symptoms of COVID for less than 5 days for people at high risk for progressing to severe COVID. And this is given as 700 of the bamlanivimab and 1,400 of the etesevimab. Look, you have to keep you infuse it over 2170 minutes, but you keep someone an hour after just to look for any reactions. This was given EUA with a study that they looked at patients who had mild to moderate COVID-19 infection. You know, there were no deaths recorded occurred in patients who received it versus those in placebo, there were 10. 9 of those 10, they thought it was COVID related. And what you saw at day 7 is a greater reduction in baseline viral load in those who received this cocktail, and a lower incidence of COVID related hospitalizations and death compared to placebo. This is the study that, again, all this is sent through the Google Drive, just seeing the comparison and where the comparison, because it's looking at these graphs, is not just where the separation is occurring, but it's right away within days of the infusion. Bamlanivimab, I mentioned in that question, but really is not supposed to be used because unfortunately it's not very good in terms of the variants. And that's why the combination is what we have here. If you're gonna do bamlanivimab, you have to use it combined. So guidelines, you know, asymptomatic, these are the Sinai guidelines, no inpatients. If you're asymptomatic or COVID positive, steroids are not recommended. If you're symptomatic and not requiring not requiring oxygen, then please advocate for your patient to consider getting monoclonal antibodies. I've had, you know, it's very seamless. Someone can call you in the morning and by the afternoon they received it. So it can be done at infusion centers throughout the Sinai system, or it can be done, if it has worst case scenario, they go to the emergency room. But the emergency room has been very versed in doing this even before the inpatient side, that they know what to do. And patients, they may have to stay there a little bit longer, but it can be done within that day. Steroids not recommended at this point. Symptomatic, again, not requiring oxygen. And this is just to kind of clarify what is that we have here. So these two are the ones I mentioned. This is the one that we have, and a little bit that I'll talk about at the end about another use for it. So another case, 38-year-old male with no past medical history, received a COVID-19 vaccine in December 23rd, 2020. He reports to Employee Health that he has dry cough fevers on January 4th, 2021. Outside testing shows that he's COVID PCR positive. what is the correct statement regarding COVID-19 PCR? I mean, vaccine. So we're getting, I still feel like there's possibilities. So what is the correct statement regarding COVID-19 vaccine? So the most common adverse effect is fatigue and pain at the injection site. It prevents COVID-19 infection. It allows the recipient to be able to visit their family and friends. Is effective after the first dose. Very good, yay. Okay, so most common adverse effect is fatigue and pain at injection site. And these you guys hopefully have seen now multiple times, and these are old articles that are placed in the Google Drive. But just again, when the effect is, so this is Pfizer, this is Moderna, and you see after randomization, people getting symptomatic COVID versus severe COVID, but just kind of seeing that, with vaccine, I think we can now say the efficacy and not meant to prevent COVID, but meant to protect you against COVID is what I always tell people. So none of these are meant to prevent getting COVID, but to give you protection so that the hope is that you're not ending up in the hospital, you're not ending up hospitalized. Multiple still things being done in terms of vaccine development, but I think Moderna and Pfizer kind of are ahead of the game still. This now is known because, over the summer things got approved, but this is just some information regarding transplant patients and just understanding that early on, this is one study for kidney transplant recipients. And what they found is that, yes, after receiving 2 doses of the vaccine, the seropositivity rate for antibody response for these patients was very low. But once they gave them another dose, and then just more information about the patients, so 65, and how first dose of vaccine, most recent transplant to the first dose of vaccine, 31 months for most people, and what type of medication was being used. And what they found is and then it just types of treatments. The main thing is that what they found is that, that the when you got 2 doses of vaccine, that wasn't enough. And so this was kind of one of the information that they used to think about giving a booster. And for some of these patients, because they did get COVID, they were able to think about using monoclonal antibodies. And this just was giving information that with the monoclonal antibodies, the persons were able to improve and go home. And then this is a slide from Pfizer, because people kept asking me, where is this information coming out regarding the booster? Well, this is because Pfizer was enrolling patients, and they came out with their data back in July of 28. And so these are the patients that are enrolled originally in the Pfizer vaccine. And on July 28, they had a press release. And this is a slide from that. And you can see that by age, so this is 18 to 55, 65 to 85. What you can see from the after your second dose, regardless of your age, you have response, but you may have less, but everyone is dropping after their 8 months. So you see that. And after they got their 3rd dose, so this is day 7 post day dose 3, and month 1 post day 3, everyone is getting response, even the 65 and 85-year-old. So this is where, now is this published? Not yet, but this is a press release from Pfizer back in July 28. Then they looked at the Delta strain, because Delta was concerning at that point, and we'll talk about that. And they showed that it was effective and good, titers and neutralization after post dose 3. So with that, a 38-year-old male with no past medical history has not received his COVID vaccine, and I hope that this is where everybody can get their points. What is the most common variant of concern in New York? So again, not about just being correct, but fast. What is the most common variant of concern in New York? Alpha, beta, delta, lambda. And that's my dad getting his first vaccine ever. And yes, I was crying, but we were FaceTiming. That's in Texas, where they had to do drive-through. So alpha, beta, delta, or lambda. Okay, very good. I would hope it's, yeah, it is 100%. Okay. Um, so it's 92 to 100% now in New York City. So, this was old information, but really what we know now is that the concern is that the viral loads in Delta infections are so high and it's actually very fit. The reproduction and how transmissible it is just so much higher than the alpha. And with that, this is a nice website in the WHO. Again, all these things will be given to you, kind of talking about each of the variants and why they're, the definition of variant of concern, what is a variant of concern and which ones are the ones that are variants of concerns. And this is the Delta that was identified in India back in October 2020. We have the Gamma that people probably have heard about that was identified in Brazil. And then beta, I know was concerned, and then alpha is the one we were talking about, but beta is also something. But right now it's gamma and delta that I know are out there. Variants of interest are those that we're looking at, but haven't caused yet, big, they have caused some community transmission in some clusters. But not yet there that it's in the interest. And here, Lambda is the one I know most of you guys have heard about. And this has been updated. This gets updated regularly by the WHO. The CDC does the same thing with the variants that are seen here. So here, this is the US, and you see here like what was happening. So alpha is the 1.17. So you see here. And the delta is here. 617.2, and you see how it just kind of takes over after June. And it gives you the information of how much there is. And then where pockets are occurring and what is the highest. Unfortunately, Texas is one of them. And then by region, so this is New York City. And so again, this is where the 98%, not 92, so 98, I put the wrong number there. But anyways, 98%. So here you just see kind of why we're saying Delta. Why is it important? Well, we talked about monoclonal antibodies. And in order for us to really say that monoclonal antibodies are effective and vaccines are effective, we have to make sure that these are going to be responsive to these variants. And that's one of the reasons that the Bamlanivimab by single was not able to be used anymore. Right now, all the ones that I mentioned have activity, but they're unlikely to be active for the beta and gamma for this one, Bamlanivimab and Isatulimab. So that's one of the reasons that we have to be on top of these variants, because it's not just it's vaccine, number one, but it's also like treatment effect. So last question, so be ready because it is the last question. So 67-year-old female on dialysis, diabetic, hypertension, completed all her COVID, or 2, so say that this is only 2, she hasn't gotten the booster. She noted that she was told that she was exposed to someone with confirmed COVID. What statement is incorrect regarding monoclonal antibody treatment for COVID-19 post-exposure prophylaxis? Okay. So which one is incorrect? So you should use it in patients who are not fully vaccinated. And we're talking about PEP. Use in vaccinated, immunocompetent, use in those not expected to mount an adequate immune response, consists of this combination. What is the one that's incorrect? Okay, so the 6 people, yes, is correct. So PEP was EUA approved on July 30th for the cocktail. So the same medication I mentioned for treatment is used for post-exposure prophylaxis. And it's really meant to be given for those not fully vaccinated or not expect to mount an adequate immune response. This was including people who have immunocompromised conditions. I think now, like with these boosters and things like that, I think we can kind of argue that maybe we should think about it for those who may not have gotten their boosters yet and may be more at risk. But this was kind of a nice study in a way that the reason it was done was because it was really for household contacts, but it also was looking at people in institutional settings, because you can actually give it for people who have been within 6 feet or have been exposed within 24 hours. And in general, here they talk about like who is considered people who are fully vaccinated. This should be updated because now we have talked about the boosters. But who are your close contacts? It says there. And what they saw is this was this phase 3 study of household contacts looking for people who were PCR positive. And when they gave it to people who were exposed, there was an 81% reduction in confirmed symptomatic COVID cases to those who received placebo compared to those who had compared to placebo at day 29. So overall, there was a reduction in just symptoms in general. And adverse effects for the monoclonals is really just some itchiness and erythema at the site of the infusion. And that was reported in less than 1% of people who have gotten it. So the authorized dose is the 600 I mentioned of the combination casirivimab and amivantamab. It's given as infusion. You can actually do it as sub-Q. For those who live in institutions that may be at high risk to another individual and they can't leave them for longer than 4 weeks, you can actually give it for repeated doses during the time that they're exposed to them in those 4 weeks. Banalunovab and islatravimab, the other combination that received EUA September 16, and that's the 700 and 1400 milligrams that I mentioned. You know, extrapulmonary manifestation of COVID is multiple talks in its own, but this is a nice talk, nice lecture, article, sorry, that I send out to you guys too. Timeline, I update this, and I think it's reason why I always want to just pause and give people a kind of an understanding. I think all of us understand, but like where we're at, yes, I have patients that think science have moved too fast, and I have patients who want to move science too fast. So it's like this spectrum. But just kind of just a summary of what's been happening. Like I said, you know, the first case was in December 2019. We identified January 2020. We have a global alert January 30th, 2020. You know, the first case here, was reported in WHO not till December 31st. And then we got the identification, global alert. Pandemic declared March 11th. First case here at Morningside and West was around that week. EUA for remdesivir was May 1st, and controversy about anticoagulation and DEX, and then we confirm about DEX. Then we have the convalescent plasma EUA January of 2020, but that had to get revised. Now we got all these monoclonals that got developed, but now we know that the banalunovab single agent is not going to work, but this one is still working, and the EUA was January 2020. Vaccines were given here in December EUA. Then we have Janssen that got the EUA, but then we also got this high titer EUA revised, so to use only high titer for those certain for those individuals with humoral immunity compromise. And that was in February. Then we got Pfizer approved in May of 2021. Sorry, for above 12 years of age. At this point, we have to hold banalunovab because it's not very good with the variants. We have TOSI EUA on June 24th. We have the JAK1 and 2 inhibitors. We have the combination now being approved for PEP, for monoclonal antibodies being used for post-exposure prophylaxis. We have booster shots now that were authorized August 12th. We have the FDA approving the first vaccine. We have the FDA now approving January of just recent last week, 22nd. And we're still, and then we have the other combination here for PEP being used, but we're still waiting for the little kids to get their vaccines. And the hope is that's going to happen in the next week or two. I was told it was like the first week of October, hopefully. And that's where we're at. And it's going to be almost 2 years now. And I think that we have to give some credit to not just all of us who've been in the front line, but also a lot of the science that's been there. And just know that it has been hands on deck this whole time, and I do believe that. But disparities are still there, and I just have to put it out there just because I saw it here just being at Morningside versus how West was impacted in the very beginning. But, you know, it's all over everywhere, and I think about local, but it's not even talking about international. So take-home phones is, as time keeps on going, we've had experience. You know, proning was something that we were doing, and teams were mentioned just to do proning. We know about mask wearing, social distancing. You know, I mentioned isolation precautions should be done with infection prevention, not anchoring on one diagnosis. I think we're really good about that now, but not anchoring on one diagnosis. the weird role of procalcitonin. ID people were not using procalcitonin 2 years ago. And the weird role of CRP that I was noticing the first weekend that I was seeing patients, what is going on with the CRP, because I did notice that the CRP, like people of high CRPs were sicker. It's just kind of crazy like that time. The use of remdesivir, kind of as the plasma steroids, anticoagulation I didn't even touch on, but monoclonal antibodies and how seamless it is now used as PEP, vaccination rollout boosters, and then just the global and local health disparities. And I just listed all there, including even telemedicine. And knowing that none of my patients actually ever use telemedicine, and still to this day are not telemedicine individuals. But now we talk about vaccination, we're talking about boosters here versus other places have not even gotten one dose yet. But just the continued communication teamwork that I really noted amongst your colleagues and the leadership, really, the one sitting here, Dr. Andrelli, and then just being kind to not just each other, but as I even tell my patients, is being kind to ourselves, as it's been a very hard last 2 years, and just being ongoing wellness and care. And it was nice to see some people having yoga earlier this morning, or I don't know when that was, but it looked nice. And then just keeping up to date. So that's why I have that Google Drive, and we just have articles kind of going crazy with the up to date. And those are all the articles, not including some that are there that will be sent by email to you guys. And with that, we are just almost not on time. So I have like 2 minutes that Dr. Andrelli grabbed.